anxiety. Objectives are to discuss the different classes of anxiety, distinguish different medications used to treat anxiety, their side effects and safety considerations, and also talking about non-drug modalities for anxiety. So you can see here, there's many different classifications of anxiety. Anxiety is kind of used as an umbrella term. We have general anxiety, panic, OCD, social anxiety, and PTSD. It's important to differentiate between situational anxiety, which is something that we all go through, when taking a test or having financial problems, versus actual general anxiety, which hangs around about 6 months or longer. And situational anxiety is something that everybody experiences at one point or another. And with anxiety, you can have your physiological components and your physical components. So you can have like your fear, apprehension, dread, and uneasiness. And then your physical symptoms can be like your shortness of breath, tachycardia, sweating, things like that. For general anxiety disorder, again, like most of the disorders we've been talking about, you always want to try non-drug therapy as well as drug therapy. So we're going to try non-drug therapy, which is, your like therapy and your CBT and things like that. And then also drugs can be benzodiazepines, buspirone, and antidepressants, which we're going to talk about. So the benzodiazepines that you'll most likely see prescribed are Xanax and Ativan. They're best for general anxiety disorder. Benzodiazepines work basically by inhibiting or enhancing your body's response to GABA. And so it's going to enhance, not mimic GABA. That's important when we talk about a few other meds in the next PowerPoint, but that's how it works. And your benzodiazepines are going to be used as needed. They're immediate onset. They don't need to build up in your system like the other meds that we talked about. So you can take this as needed, but you will see your patients that are on it once daily as well. Long-term use does carry a risk of abuse potential. If your patient is going to be tapered off of it or is coming off of it, you want to make sure they're tapered. So you want to educate them on that. Withdrawal symptoms can look like panic, paranoia, and delirium, but it's also very important to be able to distinguish between your anxiety coming through and the med not working versus withdrawal symptoms. So if a patient comes in complaining of these symptoms, you'd want to ask them, did you miss any doses? Did you forget to fill your bottle? Things like that. If they say no, like I've been taking it exactly as you prescribed it, I'm still having these symptoms, then maybe they could be just having a return of their anxiety and this medication isn't working for them and we'd want to switch it to something else. So it's very important to assess the patient in that situation. And then again, very, very important with these medications that we're tapering the patient off gradually. Buspar is another med for anxiety. It's an anxiolytic. That just means anti-anxiety. It's not a CNS depressant, but its effects develop slowly, so this is a medication that the patient will be on daily. It's not used on a PRN basis. If you do have your patient that's being switched off of the benzodiazepine to Buspar, you need those few weeks to taper down your benzodiazepine. So you may start your Buspar while they're still tapering down their benzo, because the Buspar is going to take a little bit to build up. Does that make sense? Okay. Mechanism of action for Buspar is not entirely known, but again, it's believed to increase serotonin and dopamine receptors. Also, patients, this is labeled for short-term use, not like long-term, but patients have been on it long-term and it hasn't shown like any adverse effects or any tolerance or anything like that. Continued, it's well-absorbed. It's administered with, if it's administered with food, it can cause delays in absorption, but it enhances bioavailability. Basically meaning it's decreasing the first pass effect. So there will be more of the med delivered to the bloodstream, but it may take a little bit for it to kick in just because it needs to be metabolized with food and all of that. Your adverse effects are nervousness and excitement, dizziness, nausea, headache. Some drug and food interactions. So erythromycin, that's an antibiotic. Ketoconazole is an antifungal. Grapefruit juice, I'm sure you've heard multiple times how that's just not really great to be given with most any medication. And then St. John's wort is like an over-the-counter herbal supplement that people believe helps with anxiety. So you may see your patient taking that while also taking anti-anxiety medication. So it's important to educate your patients on those. And those 4 things just potentiate the effects of Buspar and will increase the level within their system. So definitely want to educate your patient on that. And again, it has been used for up to 1 year without any evidence of tolerance or any effects. Other meds we can use for anxiety are antidepressants. We talked about SNRIs and SSRIs on Tuesday. So you already know that takes a little bit to build up in your system, and it's not used on a PRN basis. So these medications will be used for long-term management, not like acute episodes. And you can see your SNRIs and your SSRIs that are often prescribed for anxiety. They're listed here. Panic disorder. The first time that a patient experiences this, they'll likely feel like they're having a heart attack. You know, like your chest feels heavy, crushing pain, can't catch your breath. The peak intensity is around 10 minutes, but it does last approximately 30 minutes. And 50% of patients that have panic disorder also suffer from agoraphobia, which is just anxiety and panic about being in places that they can't get out of, like elevators or being in line or at a party or things like that. And panic disorder is more common in women than men. This is just an overview of the treatment of panic disorder. So you can see the non-drug therapy. We always want to try that as well and incorporate that. CBT, exercise, avoiding your sympathomimetic drugs, you know, the stimulants, the medications that make you feel jittery, like some of your inhalers or like your nasal decongestants, avoiding caffeine, your antidepressants, your SSRIs, SNRIs, MAOIs, TCAs, and then the benzodiazepines are like your as needed, although like I said, they can be Does everyone like feel okay with like the treatment options and everything? It's like a lot of repetition from Tuesday. So again, here's a few of the antidepressants listed. The anti-anxiety effects develop slowly, so again, not for PRN use. We're going to be taking this daily. And just like we talked about on Tuesday with like the SSRIs, abrupt discontinuation can cause withdrawal symptoms. So you want to teach your patients that even if they're feeling better and they don't think they need the medication anymore, or they feel that they're cured, it's simply just because the medication is working. So we want to make sure that they continue to take it as prescribed. OCD, so you have obsession, which is recurrent persistent thought, impulse or mental image. Compulsion is ritualized behavior in response to an obsession. Again, treatment is non-drug therapy and psychotherapy. You want to try that first. A lot of the behavioral therapies will basically aim at exposing the patient to the ritualized behavior. They'll do a ritualized behavior because they think that if they don't do it, something bad will happen, like their loved one will die or something like that. So basically, therapy will have the patient not do their ritualized behavior, like washing their hands, hoarding, and they'll basically see that, you know, that their loved one isn't going to die, what they think is going to happen isn't going to happen, and slowly doing that a few times helps them to like kind of realize they don't really need to act out on the compulsion and the ritual. It does cause a lot of anxiety for patients, but it does have a really high success rate, so that is done a lot. But then also drug therapy for this could be SSRIs. Social anxiety disorder, irrational fears of situations in which one may be scrutinized by others. Again, non-drug therapy, you want to do like psychotherapy and your behavioral therapies, but also drugs that patients can be on are SSRIs, benzodiazepines like as needed, and Inderal. I know you guys have all learned about that as well. That basically works by blocking beta-1 and beta-2 receptors. so that they're not getting those symptoms, those physical symptoms that they'd feel from the anxiety, like the palpitations, your heart racing, tremors, sweating, and all of that. It's usually taken like in a very small dose, 1 to 2 hours before the anxiety is thought to happen. Last, post-traumatic stress disorder develops following a traumatic event. You have your common things that most patients have PTSD from, like rape, sexual assault, car accidents, natural disasters. But there really is like no list like excluding things. Like, patients' experiences however they experience it, and someone may have PTSD from something that you don't really think is that traumatic, but each patient is different. And it's characterized by fear of experiencing the event, avoiding reminders, and persistent state of hyperarousal. Again, we always want to try non-drug therapy and behavioral therapy, but there are SSRIs that can be prescribed as well. Any questions on that one? No? It's a lot of repetition. Okay, next we're going to do sedatives and hypnotics. Objectives for this are to describe the purpose of sedative and hypnotic drugs, compare and contrast the therapeutic uses, drug interactions, and adverse effects, and also explain cognitive behavioral therapy to help treat insomnia. So, sedative and hypnotic drugs are drugs that depress the central nervous system. Primarily used to treat anxiety and insomnia. You'll hear anti-anxiety agents and anxiolytics used interchangeably. And pretty much the distinction between the two, between sedatives and hypnotics, are really just the dose. So one single med could be considered for both, just it really depends on the dosage that the patient is given. Meds we'll be talking about are benzodiazepines again, benzodiazepine-like drugs, and barbiturates. So these benzos here, listed Valium, Ativan, Versed, and Xanax, are often first choice. Also, they already have a bunch of other indications. So you can also use it for anesthesia, seizures, muscle spasms, and alcohol withdrawal. These are one of the safer meds we're going to talk about. We're also going to talk about barbiturates, but benzodiazepines and barbiturates work very similar, but benzodiazepines have a limit to how much CNS depression they can cause, whereas barbiturates don't. So we'll get into that when we start talking about the mechanism of action. So mechanism of action for benzos, they potentiate the actions of GABA. So they basically amplify the actions of GABA rather than directly mimicking it. So say like benzos are here, barbiturates are all the way up here, whereas because with barbiturates, it directly mimics GABA. With benzos, it doesn't. So there's like a ceiling to how much CNS depression you can get from them. The overview, so for the central nervous system, it reduces anxiety, promotes sleep, also induces muscle relaxation. For cardiovascular, orally, the meds don't cause much effect on that system, but when given IV in high doses or in too many doses, it can produce profound hypotension and even cardiac arrest. Respiratory, when compared to barbiturates, it's a weak respiratory depressant. It can cause depression with patients if they're already taking other CNS depressants like alcohol, opioids, other medications that depress the CNS system, or if they have underlying respiratory issues like COPD or emphysema, then you could have respiratory depression, but it's not as likely when compared to barbiturates. So your therapeutic uses, again, are all listed here. We've talked about most of them. It comes in many different forms. The medication comes in many different forms. It's lipid soluble, so readily crosses the blood-brain barrier. Metabolites are pharmacologically active. That just basically means that when the drug is metabolized by the body, it's also modified. It's it's metabolized and then it's in a modified form, which basically continues to produce its effects on the body. So basically, meaning it just lingers around longer, and that's why with like I don't know if you've heard this, but with like our geriatric population, we're very cautious with benzodiazepines because they linger around longer and they could stack them if they're taking more than one, and then they're at increased risk of like cognitive impairment or increased risk for falls and things like that. And time course of action, they all differ from onset and duration based upon the one that you're prescribed. Adverse effects, of course, CNS depression, because we're already depressing the CNS system, so it could cause too much. Anterior grid amnesia, that's just impaired recall of events after taking the medication. So you just have like forgetfulness and such after you take the med. But these are things that we want to tell the patient to report to the provider. Sleep driving is what it sounds like. It's basically when you're carrying out complex behaviors with no memory of it, such as driving, making phone calls, preparing meals. If this is ever reported, the patient should stop the medication. Of course, they'd be tapered off of it, but ultimately they'd be stopping the medication. Paradoxical effects could happen, and that's just basically opposite of the intended effects of the med. Respiratory depression, abuse. They are category, depending on which one you're prescribed, they're category B and category X as far as pregnancy. They're also avoided in breastfeeding because it does readily cross the placental barrier. Drug interactions, of course, with like CNS depressants, it's going to interact, so we wouldn't want our patient on 2 of those medications. Tolerance, with prolonged use, tolerance can develop, and then it can cause physical dependence, but is a low risk. Acute toxicity of benzodiazepines often presents like drowsiness, lethargy, confusion. If you have IV toxicity, it is life-threatening. You can have profound hypotension, respiratory arrest, and cardiac arrest. The antidote is romazicon, but that's just going to reverse the sedative effects of the medication, not the respiratory effects of the medication. So you're still going to want to keep a close eye on your patients, like respiratory status, their oxygenation, their airway, and things like that. So barbiturates, just like we were talking about benzodiazepines. So this also works with GABA, but it can directly mimic and enhance GABA. So again, it's just benzodiazepines like times 10 as far as like sedation and addiction and things like that. Overdose with this medication can be lethal because of the CNS depression that it causes and the respiratory depression that it causes. Therapeutic uses, seizures, it can be given for anesthesia and insomnia. You have your 3 classifications there. We're talking about long-acting, which is phenobarbital. That's the prototype drug for barbiturates. Adverse effects are respiratory depression, suicide, and then abuse. Again, drug interactions are just anything else that's going to depress the CNS system. You don't want to further depress it. And interactions that result from the induction of drug metabolizing meds. Basically meaning any other med that the patient's going to take that may induce or inhibit the metabolism of the medication is going to alter how the patient absorbs the med or how the med works for the patient. Either it won't give its effects off or it'll potentiate its effects. Acute toxicity is a medical emergency. This patient will definitely be like ICU level of care. It can present as respiratory depression, coma, pinpoint pupils. Treatment for this, there is no antidote, so they will use charcoal again just to get what they can out of your gut before it reaches your systemic circulation or continues to reach your systemic circulation. You'll also see forced diuresis. So the barbiturates are excreted in the urine. So you'll see doctors like give a large amount of diuresis to help push the barbiturates out of the system. But that's like tricky as well because you're also going to be giving the back fluid, and their electrolytes will probably be all over the place. So you need to keep a close eye on their volume status and their electrolytes during this. Some barbiturates are acidic, so you'll most likely be giving an alkalytic fluid like bicarb. Also, you could have your hypothalamus, which regulates your temperature, could be altered. So you want to keep an eye on your patient's body temperature, and then also supportive blood pressure and supportive care of other symptoms. So basically now just talking about sleep and basic principles. Number one thing to take away from this is that we always want to try to identify why the patient is having insomnia rather than just give them medications to help them sleep. So educating them on, non-drug therapy, avoiding naps, avoiding caffeine, exercising but not too late in the evening. And also, if their lack of sleep is because of anxiety, then instead of giving them sleep medications, you'd give them an anti-anxiety. And if their lack of sleep is from depression, you'd give them an antidepressant rather than just like a sleep medication. The drugs we're going to talk about for insomnia are benzodiazepines, benzodiazepine-like drugs, and antihistamines. The benzodiazepine-like drugs are structurally different, but they share the same effect, or they share the same mechanism of action. They work with GABA as well. All three of the benzodiazepine-like drugs that we're going to talk about are preferred just for insomnia, not for anxiety. First one is Ambien. It's a sedative. It's one of the most widely used ones. It's been around the longest. It's used for short-term management of insomnia, but it has been used long-term and hasn't shown any adverse effects or like apparent tolerance or anything like that. Its adverse effects are only daytime drowsiness and dizziness, which only occurs in 1 to 2% of patients. Also, you can develop sleep-related complex behaviors, which is basically sleepwalking, but you do complex behaviors, like sleepwalking, but you can get in your car and drive somewhere. You could make a meal, like sexual assault has been reported. I actually took care of a patient that was on Ambien to help her sleep, and she got into a car accident and got like a traumatic brain injury from it. It's very, very uncommon. It's like very low chance of happening, but it is a possibility. And of course, if something like that were to happen, the patient would be taken off of the medication. Sonata is another med for insomnia. It's indicated for short-term use, but again, prolonged use hasn't appeared to cause any tolerance. Its most common side effects: headache, nausea, drowsiness, dizziness, myalgia, abdominal pain. Lunesta, another one for insomnia. This one has no limitation on how long it can be used. The only real difference between when a medication says, no limitation on how long it can be used, it just means that it was studied longer than like 6 months before it was given to patients. Whereas the first two that we talked about were only studied for 6 months. So that's why it says like not indicated for long-term use, but it kind of works for long-term use. It really just means that they only studied it for 6 months. This drug was studied for longer, so that's why they say it has no limitation on how long it can be used. But again, it's like one of the newer meds. And it can cause a bitter aftertaste, also headache, somnolence, dizziness, dry mouth. For non-drug therapy, cognitive behavioral therapy is always going to be the most effective and safest treatment for chronic insomnia. So again, just making sure we're teaching our patient like other therapies as well as instead of just throwing medications at them. There's a chart in your book. It's on page 394 that has a long list of like sleep techniques you can teach your patient, but it's basic things, like sleep restriction, no napping, control of the bedroom, so only using it for sex and sleeping, dimming the lights, winding down 30 minutes before sleeping, reading, no bright lights, no electronics before bed. things like that are very basic that you just want to teach your patient. Just not everyone is aware of all of those things. And then this is just going over the key points to make sure you review, the indications for the meds, the risk of the barbiturates, CNS effects and potentials for dependence, and making sure that you know some sleep techniques to teach your patient. Any questions?
Yep. Are these medications then being used PRN? Like, it's not one of those things like where we're talking about depression medications where you're taking every day for 30 days to see the effects. Are these meds being taken, like if you can't sleep one night, you take it, and maybe the next night you don't, or?
Ambien definitely, it can be as needed and given daily. I think I'm confident Ambien can be given as needed, and some people do take it every day. With the Sonata, well, it says short term, so I would think that it'd probably be just while the patient is feeling the episode of insomnia. Like if a loved one dies and you're having insomnia, maybe you're going to use it short term. And then Lunesta doesn't have a limitation on how long it can be used, so I would think probably daily.
Build up in your system.
No, these are meds that work. Like, you're not sleeping that night, you can take an Ambien. Sorry, I didn't realize that you were asking. Yeah, these aren't things 2 to 3 weeks and then it'll start working. No, they work that night. Any other questions? Okay, so I have the small case studies, if you guys don't mind. So it's really just 3 different case studies. I'm going to pass them out if you guys wouldn't mind working in 3 or 4 people groups to just answer them, and then we'll go over them together. It'll really take us 10 minutes.
Thank you.
Mm-hmm. Great. Oh, okay, thank you.
Yeah.
Am I going to be in the video? Oh yeah, we're not supposed to be in it. My bad.
Not without your
consent.
Not. Oh, okay.
There we go. I consent to being in this video. My name is Trish Williams.
Yeah. Yep, you can write all over.
That the nurse manager for learning educational sessions. So you like the nurse.
Sorry, you're good. I'm just letting you know I'm sticking behind you. No, it's so much better.
Press the green up there.
Oh, pepperoni.
Oh no, and then the yellow.
I thought it was just easy. Oh, okay. Well, that makes it easier.
I wanted to bring up my. Is it okay if I go on your email? Bring up my PowerPoint one?
Yeah. Every pizza. You know, we all used to be children. Are you ready?
Do you want them to write it or just speak it out?
No, I'm just gonna have them write it, and then I'm just gonna have each group can just talk it out when we're done.
I don't remember.
I have it. I just didn't know.
What were you asking?
No, it's good. Yeah, because I'm gonna have them read their answers. I'm not gonna read it.
What
How often do they get them?
Well, originally when they first get it, they have to get it every 2 or 3 days. And after they stabilize, they get it every
No, I'm saying, so, what I'm saying, you could do, I get a 40 on ATI, and I can get a 60 on the final. So that's a little better. So he's going in thinking I'm going to get a 20. There's no way you're getting a 20. It's slow. Okay, I want to
Just one. Just one.
There's 3 things, a minute consistent.
Oh, it's like, yeah.
How does that make it better? Oh. For some reason I thought I was telling you eyes up my head. Never mind. Okay. Oh, let me have
I don't want your money.
Next time you want a Red Bull.
What's that called?
Just like playing it forward.
Don't tell them the answers. Ask them the question.
What are some adverse effects of lithium?
Not dry?
Adverse effects.
Toxicity. Yeah, but what is that like? Death?
You have no idea what it's at.
Death, yeah.
I'll be able to go
Kind of.
I'm going to.
Agitation?
Control the community.
Oh, upset GI.
Agitation's one, right?
Here, I saw that
You can't cover 14 weeks. Question, man. Bradykinesia. That's slow movements, right? It's not tremors.
It's not a type of
We're
tremor,
slow.
is it? Yeah, it's slow
Slow.
movement. Okay.
We went over in Jera, they were like, what's the official term for tremors?
For Parkinson's.
And the
Isn't
answer
it
was
the
bradykinesia.
Isn't it Parkinson's
Parkinsonianism?
or something like that?
Pseudo Parkinson's is they don't have Parkinson's. They just
That's what
mimicking
the
those
From the
yeah, from the
Yeah,
antipsychotic, blocking the
But like she
dopamine.
said, the name of the tremor is bradykinesia, but that's not.
That's like more slow.
Yeah, that's
Yeah, but that's not a tremor, right?
Yeah,
I wouldn't think a tremor.
Yeah, I wouldn't think that either.
Because like some patients will have like they gotta be moving all the time, but then bradykinesia is the opposite.
Okay,
That's
but I would
akathisia,
say
right?
Yeah.
75% of those questions didn't make sense.
Yeah.
Like, I would have never guessed the answer.
What was this? Your ATI?
No, this was
Or
this was
Jera.
like a Jeopardy like review game for
bless
Jera,
you.
and the questions were just so poorly worded. What is another one like? No, I'm not. Hey, no, I'm not shaming her. She just helped with trying
It's
to
one of the
help.
things, but it's not what they're called. It is a side effect, but it's not what they're called.
Yeah,
so with a tremor.
But anybody want the right
Bradykinesia
to present there?
is a symptom, but
Of,
it's not.
but it's not the tremor.
What's gonna be about?
Do you want to present?
I think Misha said something.
I did.
You left when they said
when
case
was it?
study in the town.
Oh, so now she got a
We
percent.
have a group that's gonna read their answers, guys.
Yeah.
Yes, please. Everybody has.
A nurse manager is preparing an educational session to review client use of benzos for the nurse quality unit. Identify 4 therapeutic uses for benzos. We have insomnia, alcohol withdrawal, anti-anxiety, and seizure disorders. Next is identify 3 contraindications for taking benzos. We have another CNS depressant, pregnant or breastfeeding, and if you have another breathing issue like COPD, emphysema, asthma. The last thing is list 3 things you would teach a patient when being prescribed this medication, and we have taper off instead of abruptly stopping, don't use with other opioids, and monitor for withdrawal symptoms.
That's great, good job. Does anybody else want to read theirs?
I'll go. So we have a bipolar case study. A nurse is reviewing discharge instructions with a patient who has a new diagnosis of bipolar disorder. The client has a new prescription for lithium 600 milligrams PO 3 times a day. Includes 3 adverse effects the nurse should include in the teaching. So we put GI upset, confusion, and EKG changes. So then for that you get a baseline EKG before and monitor. 2 teaching points: don't stop taking it abruptly, and make sure you get your labs checked regularly. It has a narrow therapeutic index, so we don't want them to become toxic. And then instruct the patient when their next set of labs will be, and when they first start, it's 2 to 3 days, and then once they get in their levels, it'll be every 3 to 6 months.
Great. Good job. And the only difference, like the GI upset you said, the transient is expected, but if it was persistent, that could mean toxic levels. Great. Anybody else? Yeah, that's okay. Do you have anything else you'd like to add? Or anything that that they put that you didn't put?
We also put don't take NSAIDs
Yep.
when you're taking it. And then we also put memory impairment and polyuria are 2 adverse effects.
Great.
And you can tell them, like, if don't abruptly change your sodium intake without consulting your provider first.
Yep. Awesome.
Because it's high, low sodium, high lithium.
Yeah. If you're hyponatremic, it's going to hold on to your lithium. It's not going to excrete it out.
You can't take diuretics.
What's the one with Didge?
Insects.
Yeah.
If you had high sodium and you were taking lit, would it do like kidney damage or something? I'm trying to, like, if you're overloaded with sodium and lithium, or like would your body basically excrete the lithium?
If you're meaning if you were hypernatremic.
Yes.
Your body would still process the lithium the correct way.
Okay.
And you wouldn't be at risk at a toxic level, but lithium itself is damaging and can be damaging to the kidneys.
Would it be the opposite, like if you have low sodium, you hold on to lithium? If you have high sodium, will it excrete more lithium, so you lower your lithium levels?
No, I think if your lithium levels are hypernatremic, it's still gonna excrete your lithium out. I don't think that affects your levels. Professor Solomon, did you?
Oh, I'm sorry. I was thinking about her question. Go ahead, say it again.
They're asking if you're hypernatremic, is that going to affect your lithium?
Like, are you going to excrete more lithium then? Just like how if it was low, you would hold on to more. If it's high, would you excrete more?
Would you possibly have a
you would just monitor more closely just to make sure it wouldn't be like a subtherapeutic.
Yeah. I think in the book when I was reading, I don't think it mentioned how.
So you monitor for subtherapeutic effects, to make sure it's going to be effective.
Yeah.
But
So the NSAIDs, alright, we got these things called prostaglandins in your body, and they work different ways in different areas. In your stomach, they protect the mucosa, like the stomach lining. So NSAIDs inhibit prostaglandins, so NSAIDs mess up your stomach lining. Yeah, just like this. Like you ever take a ibuprofen on an empty stomach? It irritates your stomach lining because it inhibits it.
You did? Yeah. I've done that so many times.
Yeah, that long med is an MIOI. It just, I was just giving you the different name.
So looking through it says identify 3 expected findings. So they're having an adverse reaction, how we what they
Yeah.
And then with the hypertensive crisis, are they having something? I don't really know.
No, so by the question I just meant what do you think happened there? And what do you think their blood pressure is gonna manifest and things like that.
Oh, okay.
Yeah. So it's basically I got the questions out of this book, so it's basically wanting you to detect that they're on an MAOI, they ate something with tyramine in it, and that their blood pressure is high.
Okay.
Something that you'd expect to find, you'd expect to find their blood pressure high. You'd expect that maybe they're not following their dietary restrictions, which they basically told you that they were.
And then so for a medication appropriate, you're not going to say, oh, you need a different antidepressant. You're just going to treat what they have right there with blood pressure.
Well, you would treat their blood pressure, but the following question was basically, are you talking about the question that says, like, what do you think the doctor would?
It says identify at least one medication appropriate.
Okay, so, yeah, I mean, you could talk about the blood pressure medication that you treat, but also, what would you do for this patient? Like, what do you think you would do? Aside from treating them physically, moving forward. Yeah, so, like, talk to them, like, did you understand that you couldn't have pepperoni and you just didn't want it? Listen, you know, like, see if they're gonna be adherent to their restrictions, and if you think not, if you think it's probably not safe, they're obviously not gonna listen or they don't understand, and education may not be helpful enough for them, then yeah, like an SSRI or switch them to something else.
Okay.
I gotta check with Don. He's mad at me right now because I'm not getting the party together to his liking.
Yep, perfect. Good.
I
You
did.
guys wanna go?
I talked to your
Yeah,
cousin
sure.
and I
We're the same one.
Same one, anything to add?
I don't know that we have much to add. 3 expected findings, we said hypertension, shortness of breath, chest pain. For one medication that would be appropriate for treatment, we said nipride because it's a vasodilator and hypertensive
no,
crisis.
text your cousin.
And then
tell
the dietary
her I sent over
sources,
the email.
liver, caffeine, cured meats, cheese.
To pay.
Great.
Yeah.
Alright.
She said
They
she's.
did all the heavy lifting on the
Yeah.
medication stuff.
Hold on one
I
second.
really
She said
appreciate you guys
3,500. Crystal, I'm gonna call you right back, right? I'm in this class. All right.
Thank you.
Nope,
Thanks, I
you can
stole
throw 'em
all
out.
of it from 6.
They said they'll take you without your license down here. 3 to 7.